I work for Omina. We're a Belgian scale-up, started 2016, always has been focusing on ethical explainable AI. What that means is that if we are indeed a patient, if we're in healthcare, that the patient has a right to understand what it means. Why is this diagnosis made? How does it affect me? What can I do with this thing? In a way that he understands. So, and that's also the agenda, what I then want to talk today about, is first of all, diagnostic errors and the root causes. Then we want to see how can diagnosis be improved by adopting this more holistic precision medicine type approach, where I'm going to talk about what we need to do. We have data, biomarkers mostly mentioned or measured in a single domain, single dimension. We need to move towards multidimensional data representation and analysis by AI. We also then have to take into account explainability and understandability. And I know these words are kind of hype words, but we'll go into our interpretation of them and with references throughout. And of course, then I will end up with the summary, like what does this mean? What is the next steps? How can we make this a reality? First, we have to accept that currently, 1 in 20 US patients are impacted by diagnostic errors. Of course, it's important because it has a huge impact on their quality of life, because if we give someone a wrong diagnosis and we give them wrong treatment, there's a good chance we actually give them another adverse event, maybe create another illness. Also, because of that, there's an increased cost in healthcare. Now, what we see is that most of these diagnostic errors come because we have an overly simplistic representation of reality. Typical example, diabetes, type 2, usually measured with something like fasting blood sugar, where you then have a value that you should be above, which is based on the whole population. If you're above the value, you're considered diabetic. But it ignores a lot of other aspects. Let's say if we have a condition that makes our blood sugar higher by default, but with this measurement we're classified as pre-diabetic, we're going to get treated as a pre-diabetic, we can actually develop another disease. So again, we're underrepresenting the true biological complexity. Nice example, most of us know this. I'm not sure if it's the same in all countries, but at least in Belgium, the COVID vaccination strategy was based on a patient's age and if they're immunocompromised. Over time, we have seen that conditions like obesity have a huge impact. So whereas maybe the strategy should have been focused on people with obesity first rather than age. And we may have been able to prevent quite some complications. So this is one of those confounders or let's say other effects that were not taken into account. Now, if we then also look at how you would interpret such results, let's say here we have some data on a paper we worked with University of Oxford and a pharma company near there, where we have mature onset diabetes of the young, MODY diabetes, which can be measured with certain types of sugars in your blood. On the right, we have a healthy population. Let's ignore the two groups in the middle because they're too small. But on the left, we have then the condition for people who have MODY, this genetic diabetes type. If we have now a patient that is on this red line, is he healthy? Does he have diabetes? I honestly would not know. So if you now present this to a test, it's going to say yes or no just because it's just above this threshold value. So this then leads us to that when you look at these misdiagnoses, 13.7% of the outpatient diagnostic errors in primary care is caused by performance or interpretation of diagnostic tests. Again, related to the fact that we're using a too simplified representation of reality. So how can we improve this? We have to capture the full complexity, or at least more than we do right now. So you see, there is some research going on this. There was a paper published a few years back where they took genomic and glycomic data and basically did a genome-wide association study, which showed already this extra domain and which could then be highlighted that certain diseases or conditions you can see in the glycan are directly correlated to certain SNPs. And it's already better, but it's only 2 dimensions. But on the other hand, we also have to make sure that when you go to these more dimensions, the data becomes thus highly complex that you have to make it able or processable, let's say it that way, by a healthcare practitioner, by a patient in the end, because in the end, the final customer is always the patient. He needs to understand why the doctor thinks something, what it means for him. But when we go to this higher complexity in biology, what that means is you're actually going towards this more holistic biological model, where if we want to capture an individual's complexity rather than basing it on the whole population, we have to track also each individual domain through time. It's quite sufficient to measure someone's genetic profile once, because it should not change. Not looking at epigenetics here. But for instance, someone's glycome profile or microbiome profile, basically what we eat or the sugars in our blood, have a throughput time of roughly 2 weeks to a few months. So you have to measure them more. Now, if you measure these more, you can actually have a profile of a patient through time. And you can then start identifying the patterns, like moving away from the patient's norm. And if we have that, then you can sort of prevent or identify when such a pattern is going to lead towards a diseased profile. And because having more dimensions, you should also be able to ignore or correct for these confounding effects. But, so with this increased complexity in the biology side, you also have an increased complexity in the analysis methods. Now we see that AI is being used more and more in the multi-omics types approaches for diagnostics and prevention prognosis. But when you then do an analysis on the type of methods that are being used, there's a really nice review. References are all in the slides at the end for someone who's interested. But there they analyzed the methods that were being used in these multi-omics domains. And what you see is there's a rapid growth of the type of methods being used, with also then each type having their own, let's say, performance in terms of reproducibility and robustness. But what you can see is that if you look at the general trend, is that clustering and network analysis are the more commonly used approaches. Of course, this will evolve over time, but you also see that none of these things here go beyond the, this patient is going to get sick, yes or no. There's no why. It's generally not put in most of these papers. So what do you actually need to increase adoption of an AI-enabled multidimensional biomarker? I can speak from personal experience, having built biomarkers for inflammatory bowel disease. Going to the healthcare practitioner and trying to explain them why they should use this is a hard subject and something that most people don't do. And you don't want to end up as biomarker number 100 that is just not being used. It's a waste of effort. So you have to take this step further. And this is something where normal AI scientists just don't know. You need expertise in both domains. But if we then look at what is required, we need to build acceptance. That the healthcare practitioner can accept a model, that it understands why. We also need to give them all the information they need to have efficient communication with their patient. Only when you have that will a patient trust, hopefully, the prediction the system makes. And I say prediction because it should always be a prediction. It should always be the healthcare professional, of course, that makes the choice. If he trusts the system, if he disagrees with the system, they should also let the system know, because the system should learn from your brain expert. There's also one thing where we do. We're actually quite involved in some patient partnerships teams, where we communicate with the patients, what is it that you want? How do you need this? How do you want to engage with healthcare? How do you want to have true stewardship or ownership of your data? But so let's take this ACT concept a bit further. There are concepts called Interpretable AI and Explainable AI. And as I said, there are a few definitions for these. The definition that we use here is that interpretable AI explains how a given biomarker comes to its prognosis. So for instance, if we have linear regression, it is literally just the function. Then you have explainable AI that says why a given biomarker came to its prognosis and diagnosis. I want to focus now one slide on the explainable AI, because this is a field that has been quite well researched by AI scientists themselves. If you were to use a technique, if you know the technique, props to you, but let's not go into the details. You can get an information about what are the features that made the model an important model. So which are the features that drive certain groups? So this is a data set from COVID-19 that we took from a partner that we have in Mexico, let's say. And there you see that pneumonia, age, gender are the key drivers for the total population. If you now look at an individual, this individual at the bottom has a lower risk for COVID-19. Why is that? We see that because she is actually female, relatively young, is not obese, the chance is much lower for her to get COVID-19. But it doesn't really go far enough. Because why do these things matter for the biologist, like the healthcare practitioner? Some of these are easy, but what you would like is an information like obesity is relevant because a certain reference, something they can actually check. You can even go that one step further. If you have certain features coming together, you could go through the literature. Where do these features come together as a phenotype? What are the things that you see? What is the diseases where these things occur? That's why there's a term that is commonly, well, not common, it's getting more and more common, understandability. And this is the definition from the most recent paper. It is nice, but it's not directly workable. So there is actually a translation of said definition made by Forbes, which is, in a sense, better. It means that you give an explanation to the patient, adjusting your explanation based on the patient's understanding, perspective, and interaction with it. So you can cater it as you are giving it. So what you need for that is you need to know the context of the patient, of the disease. You need to know the knowledge of the patient, the knowledge required by the model, etc. And you need to include storytelling concepts. Now let's go into detail about those three concepts. In terms of the context, I already mentioned just now parsing through the literature. Where do certain features occur together? So that's the scientific literature. So if you have certain features, you need something that parses, for instance, PubMed, whatever picture fancy, finds the papers where those features come together, present them, listed by most likely importance, where also other physicians can then rank, like, the system right now thinks that this paper is more important, but I don't agree. So that all physicians teach the system also what is actually good literature. You need to find the interactions between certain features. Like if you have features that belong to respiratory diseases and you have another set of features that belong to pneumonia, there is an interaction there. You have to cover this. And you need to take care of the environment. What I mean there is the patient from an environment of high air pollution, what's his socioeconomic status, etc. The knowledge here refers to the knowledge of the healthcare practitioner, because when we give the explanation to the healthcare practitioner, we also have to make sure we don't speak in a language that he cannot understand. But the same goes for the patient. So you're going to have two flows of explanation almost, using the knowledge of both. And here you can think of knowledge graphs. So if you can model the knowledge required by the model and the knowledge required by the patient, you can then find the shortest path using basic graph theory, which of course still a mathematical representation. It's not usable in normal, let's say, day-to-day conversation. So you need to have a bit of NLP, and I'm going to hand wave the complexity away here. But you need some NLP around that makes that into an actual story. So we have the mathematical explanation. Now, how do we make a nice story about that? Now, that is all the concepts we need to work on to make this understandability a reality. And that is also the only way that I see, or we see, how we can reduce the diagnostic errors by basically evolving from this traditional healthcare where we look at population-based tests, we have average values. You're going to have a lot of, I don't want to say wrong, but maybe not the best diagnosis, because you don't look at the complexity of the system, the individual system, and then move towards this holistic approach where you take each individual as a complex system and track them through time. Because the only thing that matters is their deviations from their normal. Or, comparing to the population, if the entire population is changing, but one individual is not, that also means something. And we can get there by adopting this AI-enabled multidimensional biomarkers and using explainable AI and understandability to increase the adoption. And hopefully then we can get to like the most recent dogma change in healthcare. And I'll give bonus points to whoever recognizes this person and why that is relevant. Now, here are the references for people who want to see them. You can also see them at the end. And if there are any questions. Just scream up, I guess. Or is there a microphone? Perhaps no, right? Okay, just speak loudly.
So I think you said that it should always be the physician who has the ultimate decision. But I think recently a paper was published in which they asked radiologists about an algorithm that predicted breast cancer way better than they did. Would you trust yourself or the algorithm? And of course they trusted themselves more often. But my question is, when will be the moment that we say, okay, we won't trust the physician anymore, but we will rely on these prediction models?
There's a cop-out easy answer. I'll give that, and then we'll go more into detail. The moment we can do that is when a computer can have legal status. However, the better answer would be, especially in vision, because assuming you were talking CT scans, something like that, computer vision, right? There, indeed, neural nets and similar systems are very good performers because they can take a lot more visual information than most people can. However, I think the way to go is to present all the parts of the cell, sorry, not cell, slide we recognize, color code them accordingly. If we even have imaging mass spec, you can see protein localization of something. Present this data to the physician and say, we think this. And they just have to say, do we agree, yes or no? Because again, as I said, there needs to be liability aspects. We can just filter, we can make your life easier, but we should never make a prediction.
On the same note of that question, in a way, you have to convince the physicians that your algorithm is going to help them, is going to improve their diagnostic power. So you want to think about how you're going to influence the patient, right? Or how you're going to help the patient, but also how do you convince the physician, right, or change their perspective from I'm going to trust my instincts versus I'm going to trust this AI algorithm which can help them.
Pardon, there are several aspects of that. Adoption is of course a tricky one. The way I see happening with the best success is actually have such a system run parallel to the physician. So your physician makes your prediction, and they at the same time, in parallel or afterwards, can see the algorithm would have thought this because. I focus on the because. We always have to give the because. Nobody wants to have a computer that says A, or you have to tell your patient because computer says so. It's never going to fly. But if we can convince them and even show the algorithm improving over time, because we have to be realistic, early versions of similar algorithms will never be perfect, but they will improve over time once they start seeing how the doctor diagnoses. Because you can even have a scenario where you have an AI with a bit of customization for each physician, that this AI will mimic this physician's exact diagnosis. If that is desirable, that's another question. I'll leave that up for debate. But we can go that way. So you have to prove to them over time, and they will then start hopefully trusting that the system can save them time just by doing this initial filtering, like which slides, if I didn't take the previous example, which images are relevant or useful. Does that answer your question? Anyone else? All right, I would like to thank you all for your time. If you want to have any further questions or discussions about this, I will be downstairs at booth 18, which is on the right if you're looking at the main stage. All right, thank you.